is Adrian Martin, and I'll be doing a presentation on ICU Delirium. The ABCDEF bundle stands for Assess and Manage for Pain, both spontaneous awakening and spontaneous breathing trials, attention to the choice of sedation, delirium monitoring and management, early mobility and family engagement. With this bundle, it creates an easier way to implement safety changes necessary to adequately care for these patients in the intensive care units. Today's intensive care units keep alive patients who would not have survived 20, 10, or even 5 years ago. ICUs have come so far in curbing problems like sepsis and acute respiratory distress syndrome that they've created a huge population of ICU survivors. Those who make it out alive but end up severely impacted mentally and psychologically. Delirium is inattention and confusion that represents as the brain temporary failing. A person who is delirious is unable to think clearly and can't make sense of what's going on around them. Patients treated in intensive care units who are heavily sedated and on ventilators are likely to become delirious. Some studies place the rate as high as 85%, with an estimated cost being more than $143 billion annually to hospitals. The objectives for this presentation is to educate staff on the importance of delirium prevention and monitoring. Education on monitoring including CAM, ICU, and RAS. Optimizing pain management. Breaking the cycle of deep sedation and prolonged mechanical ventilation. Reduce the incidence and duration of ICU delirium. Improve short and long-term ICU patient outcomes, and reduce healthcare costs. The rationale from our project and the root cause of delirium is intensive care units is sedation, medication, and mechanical ventilation. Oftentimes, intensive care units associated delirium goes unnoticed as it can be presented as restlessness, agitation, flat affect, or either a combination of both. Longer hospital stays, increased cost, mortality, and time requiring mechanical ventilation can also be associated with the development of delirium. Nearly 75% of ICU patients develop delirium during their hospital stay. In roughly 1/3 of those cases, their cognitive problems were so severe that even 1 year after discharge, they mimic mild traumatic brain injury. These findings led to the implementation of the ABCDEF bundle. The bundle is necessary to help reduce practice variation, standardize care, improve ICU team communication, and overall improve patient outcomes. My PICO question is, can a bundled approach to care of the adult critical care patient result in improved provision of timely and coordinated awakening and breathing trials, safe progressive early mobility, and early assessment of delirium without increasing length of stay or ventilator days? The evidence for change. The ABCDEF bundle is a group of evidence-based measures aimed at standardizing communication, improving interdisciplinary patient care, reducing mortality, and improving long-term cognitive and functional outcomes. This just breaks down again the ABCDEF and what exactly they all mean. The importance of the spontaneous awakening trials, spontaneous breathing trials, early mobility with physical therapy, and making sure we're reorienting our patients and notifying the families that this is important to help prevent delirium in our patients. My recommendations is to reduce the use of sedatives and ventilators and push patients to get on their feet as soon as possible in a bid to minimize delirium. Throughout this research and implementing the prevention and treatment of ICU delirium, nothing was found that I believe our team in the intensive care unit could not accomplish. As a team, one is able to follow the CAM, ICU, and RAS to assess for ICU delirium. Assessment of agitation and sedation are key. Prevention is maintained through performing early mobility and delirium monitoring using the confusion assessment method for intensive care units, also known as the CAM ICU. The CAM ICU is the most reliable form of delirium assessment, and routine assessments is important. The most reliable method for assessing for agitation is the Richmond Agitation Sedation Scale, also known as RAS, which is used to measure the depth and quality of sedation. Through the use of spontaneous awakening trials, the nurse will be able to wake the patients up by cutting the continuous sedation medication off. If it is necessary to start the medication back, they must start the continuous infusion back at half of the rate and increase the medication to reach comfort on minimal sedation. Spontaneous breathing trials will be performed daily by respiratory therapists after the patient has successfully been awakened off of sedation. This will require teamwork between the nurses and respiratory therapists to promote decreased time spent on mechanical ventilation. With the help from physical therapy, early mobility can be achieved. The use of these disciplines will help to overall improve patient outcomes and prevent delirium. This is an example of the CAM ICU flow sheet and how exactly we will monitor for delirium. If we notice a change in patient's mental status, that'll kind of send us a message to we need to check for delirium. Are they able to follow simple commands like squeeze my hands when I say a certain letter, or answer simple questions? Next, this is an example of the Richmond Agitation Sedation Scale, and pretty much it's just a table showing if the patient's, for example, if the patient's not fully alert but can sustain being awake for more than 10 seconds with eye contact, that would be a -1, drowsy. So it just kind of gives you a description and a number to go along with it. Next, this is a mobility chart to just show, depending on what their RAS is, as mentioned previously, exactly what type of mobility they can participate in for that day with physical therapy. For example, if their RAS is -3, -2, they can do passive range of motion and sit on the side of the bed. Evaluation for this implementation should occur within 6 months and include auditing numbers of ventilator-free days, prevalence and duration of delirium, documented RAS -4 or -5 without a physician order, ICU mobilization frequency, ICU and hospital mortality, level of consciousness in our patients, and discharge disposition. The expected outcomes are more effective when implemented by nursing, respiratory therapists, physicians, pharmacists, and physical therapists working together as an ICU team. This is just a table showing that for pain, we're going to use the CPOT, the Critical Care Pain Observation Tool. For agitation, we're going to use the Richmond Agitation Sedation Scale, and for delirium, we're going to use the Confusion Assessment Method for the intensive care units. And this over here just mentions, again, what exactly the A, B, C, D, E, and F stands for in this bundle. In conclusion, assessing for delirium, choosing sedation wisely, and pushing patients to early mobility is the key. Reducing the use of sedatives and ventilators, as well as pushing patients to get on their feet as soon as possible, will help to minimize delirium in our patients. Ensuring nurses have the knowledge and the right tools to prevent and manage delirium. I believe through the use of teamwork, we can all support each other at the bedside to improve this point of care and overall improve patient outcomes. This last slide is just a slide of all the references that I used to develop this PowerPoint presentation and the information I just provided to you. Do you have any questions?
Excellent.
Thank you.